Well, thank you everyone for another series, another great talk on highlights in neurosurgical oncology. Today we have a special guest, a neuroradiologist, Dr. Mark Wintermark, who is a Swiss and American neuroradiologist, a brain imaging expert, who pioneered perfusion scanning of the brain, which is quite amazing. Wintermark is currently a professor and chair of neuroradiology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Previously, he worked at Stanford and at the University of Virginia in Charlottesville, and he trained in Lausanne, Switzerland, and at the University of California, San Francisco. Wintermark is the president of the American Society of Neuroradiology and the editor-in-chief of the American Journal of Neuroradiology. He'll be talking about advanced imaging techniques in neurosurgical oncology, which are essential for us and for our understanding of how we treat patients. And please, thank you for participating, Dr. Wintermark. It's a pleasure, and please go on.
All right. Thank you so much for the kind introduction and the kind words, and thanks for having me. I always love speaking with my colleagues from neurosurgery. It's always interesting and fun. So today I wanted to, as the title of the presentation says, talk about different advanced neuroimaging techniques that are frequently used for the patients that you see in your clinic and in your operating room. I'm going to start with perfusion imaging. As you know, there are different types of perfusion imaging. There are basically three different types. One called dynamic susceptibility contrast imaging, DSC. One called dynamic contrast enhancement, DCE. And finally, there's also another technique called arterial spin labeling, which we typically abbreviate as ASL. And I'm going to give you a little bit of information on those three perfusion imaging techniques. The first thing I can say is the first two, the DSC and the DCE, use gadolinium contrast, whereas for the ASL, about which we'll talk later, you do not need to inject any kind of contrast, but rather you use the patient's own blood as a contrast agent. But let's start with DSC. So DSC is illustrated here. For DSC, basically, you inject a relatively short bolus of gadolinium contrast. And, you're all familiar when you inject contrast, you look at the post-contrast T1 weighted images, and you see some brightness where the tumor enhances. So that's one effect of the contrast agent, is to increase the signal on the T1 weighted images. But the gadolinium contrast has also a different effect on T2 and T2 star weighted images. And when you have the transit, the first pass transit of a bolus of gadolinium contrast, you actually have a decrease in signal when the contrast washes in. And then after that, the contrast basically recovers, at least partially, to its baseline level. And you can extract two pieces of information from that dynamic that can be observed in every single voxel. The first one is kind of how deep is that drop in signal. And that typically tells you something about what we call the cerebral blood volume, which is basically the total amount of blood vessels that you have in a given voxel in the image. And of course, you can calculate that in every voxel, and then you can create a CBV map that shows you the status for the whole brain. So that's the first piece of information that can be extracted from the DSC imaging. The other piece of information that you can extract is about the degree of recovery. So if the blood-brain barrier is mostly intact, you are going to have a good recovery, and typically the signal is going to go back to where it was before the bolus of contrast arrived, or close to it. Whereas if the blood-brain barrier is significantly altered, you are going to have a poor recovery or no recovery at all, and you could observe in some cases that you have no recovery at all. And so that's another useful piece of information. So again, you get some information about the cerebral blood volume and you get some information also about the blood-brain barrier, again, from that dynamic susceptibility contrast, that DSC perfusion imaging. And I'm just going to show you a couple of ways that you can use that information practically that is relevant to your practice. So here are two different patients. They both have an enhancing lesion surrounding by an area of increased T2 signal that is not enhancing. And when you look at those images, so of course, and of course you're going to think more of metastasis. And if the other patient doesn't have any history of primary, you may think more about the GBM. But from an imaging perspective, they look very similar. And also, sometimes you don't know, because sometimes the first presentation for the patient pattern, and you still need to differentiate between a glioma and a solitary metastasis. And so there are two ways that you can do that. So the first thing that you can do is, again, look at those curves, and you can look at the amount of recovery. And typically in a glioblastoma, in a glioma, but there is some blood-brain barrier, at least partially preserved. And so typically when you interrogate the enhancing area, you're going to see that there is some recovery. It may not be a perfect recovery all the way to the baseline, but you have a pretty good recovery. And that typically tells you that there's some, at least a certain amount of blood-brain barrier that is preserved. Glial brain tumor. Whereas if you deal with a metastasis, typically metastasis don't induce the angiogenesis of vessel with blood-brain barrier. So typically when you interrogate the enhancing area in metastasis, there is going to be very poor return to baseline or no return. Presented with a solitary enhancing lesion to try to differentiate a primary glial brain tumor from metastasis. The other thing that you can use is you can look at the area of abnormal T2 or flare signal surrounding the area of abnormal enhancement. Because again, in a metastasis, and it's illustrated here, the tumoral cells in that area that has the abnormal T2 or flare signal. Whereas primary glial tumor are infiltrative tumor. And of course, we know that the enhancement is, created by the tumoral cells, but there are also some tumoral cell extending in the surrounding region of abnormal T2 and flare signal that's, and it's always going to be increased in the area that is enhancing, both for glioma and metastasis. But if you interrogate the area surrounding the enhancement, you'll see that, for instance, for that patient, the cerebral blood volume is actually not increased. And that tells you you're probably dealing just with vasogenic edema, diagnosis of metastasis. Whereas for that second patient, when you interrogate the area of abnormal flare, T2 signal surrounding the area of enhancement, you can see that the cerebral blood volume is actually increased. And that suggests that actually it's not just plain vasogenic edema, but that you have a little bit of tumor perfusion, even if it's not enhancing, and therefore it pushes you towards the diagnosis of primary glial tumor. So again, two ways that DSC can be helpful in that particular situation. One way is to look at the recovery or lack thereof of the curves, at the permeability of the blood-brain barrier. And the second one is to interrogate the abnormal T2 signal or flare signal surrounding the area of enhancement. Another situation where perfusion imaging is helpful is when you follow up patients and when you are trying to determine if new enhancement corresponds to recurrent tumor versus radiation therapy changes. So again, in both settings, you are going to have enhancement because in both settings, the blood-brain barrier is typically abnormal. And so that's why you see the bright signal on the post-contrast T1 weighted images. But the big difference is when you look at the perfusion imaging and at the CBV, if you are dealing with radiation treatment changes, basically, you don't have a lot of vessels. You have very few vessels, but they are very leaky. So again, that explains why it's enhancing. But when you look at the cerebral blood volume, you can see that there's actually no increased cerebral blood volume. Actually, it's decreased, if anything. If we're dealing with tumor recurrence, then you would have typically increased cerebral blood volume. So a good way to differentiate between, again, recurrent glioma versus treatment changes. And here's was an interesting case where, again, so we imaged the patient the first time. You can see that the cerebral blood volume was decreased, suggesting that we are dealing again with radiation therapy changes as opposed to recurrent glioma. And on the subsequent follow-up, the patient developed an area of increased cerebral blood volume, not at the primary site, but adjacent to the atrium of the right lateral ventricle, probably as part of some dissemination of the primary brain tumor. And again, you sometimes may see that increase in cerebral blood volume before you see the abnormal enhancement developing. All right. So again, here's another example side by side of real progression versus pseudo progression. So again, real progression, you see there's all these new abnormal enhancement, and you can see that the cerebral blood volume is increased in those areas. Whereas for the second patient, there is also abnormal enhancement, but there is no increase in cerebral blood volume, suggesting here that we're dealing with progression for the first row and with treatment changes or pseudo progression for the second row. And here again, another example, and again, same kind of finding where again, you have this abnormal enhancement, but it doesn't look like the blood volume is increased, suggesting again that we're dealing with treatment response and pseudo progression. And there are now tools that are available out there where you can basically try to quantify that. As you all know better than me, actually, it's not always that it's one or the other. It's not just tumor recurrence or radiation therapy changes. Often you have a combination of both. And so now there are tools that are available where you can basically look at the cerebral blood volume as a map, and you can quantify that in an histogram, and you can see it's called the fractional tumor burden. And you can see that in this particular situation, the majority of the enhancing area has actually low cerebral blood volume. And there are a couple of voxels here in the deep component where the cerebral blood volume is a little bit more increased. There's also a very tiny area peripherally where it seems that the CBV is actually significantly increased. So it suggests that the majority of these lesions consist of treatment changes, but there may be a couple of components where the glioblastoma is still present and may grow in the future. And here to contrast it, you have a different patient where you can see it's exactly the opposite. And you can see that when you look at the areas of abnormal cerebral blood volume in the enhancing area, most of them have, the red, very increased cerebral blood volume. And therefore, that tells you that most of that enhancing lesion is actually a progression of the glioma. So I wanted to show you those tools. I'm now going to move on to the elegant version of doing perfusion imaging called ASL. So ASL stands for arterial spin labeling. Patient, rather we use the patient's own blood as a contrast agent. And the way ASL works in a nutshell is you first take an image of the brain at baseline. Then you label magnetically the blood in the neck of the patient, in the carotid arteries. And then after a certain time interval, you take another snapshot of the brain And by performing a subtraction and applying a mathematical model, you are able to extract cerebral blood flow information from that difference that you observe between the labeled image and the control image. And so that's the way it looks like. So again, here I wanted to show you a comparison of ASL, DSC, and in this to make you aware that there are some pitfalls in ASL. So again, in these patients, it looks like the patient is missing perfusion in their left ICA territory. And so what's happening? Is it that the left ICA is occluded? Is it that the patient is having a stroke involving the left ICA? Well, you can see on the MRI that's not the case. But this patient, as you can see, had metal artifact. They had some kind of sinus surgery, a surgery on their mandible. And therefore, it creates an artifact here, and it cancels the signal from the left carotid artery. And so when you label the images in the neck, basically this carotid artery, the signal, the magnetization signal that you label the blood is getting dissipated by that artifact. And therefore, when you measure it in the brain, you have no signal. So something important to remember from ASL is, again, you are measuring that magnetized blood, and there are several circumstances where you can potentially have pitfalls. And ASL has been used, abundantly for different conditions, for patients with stroke, for patients with moya-moya, a very nice way to perform DIMOX tests, because you can do ASL before and after DIMOX, because you are not injecting contrast. You don't have to inject the patient twice. You, again, just do ASL before and after. And it has also been used for patients with brain tumor. And the concept is this, the technique is different, the way you get your measurement is different, but what you measure is very similar. It's the cerebral blood flow instead of the cerebral blood volume. And again, in the setting of pseudo-progression, you are going to have decreased cerebral blood flow, whereas if it was real progression, then you would see an increase in the ASL. And so again, here, in a patient, you can see that the measurements of ASL get better and better over time. So despite the enhancement at first increasing and then decreasing, you can say with confidence that actually the patient is responding, and that's just, again, pseudo response. The final technique that I wanted to describe is called DCE, or dynamic contrast enhancement. So for this one, again, you inject contrast, but this time what you are looking at is a little bit different. I mentioned to you that in DSC, you look at the first pass of the bolus of contrast agent. And in ASL, you label the blood of the patient magnetically, and you kind of also look at the first pass. For DSC, you do not look at the first pass. You look at the equilibrium of that contrast agent between the vascular compartment and the interstitial compartment. And that typically, instead of being this first pass over, 1 minute, it's typically something that you look at over 5, 6, 7 minutes to see, again, how slowly the contrast agent basically extravasates from the vascular compartment into the interstitial space. And while DSC, the first one that we saw, is very good at measuring CBV and can also give you some information about the permeability of the blood-brain barrier based on the degree of recovery of the curve. But again, for DSC, the primary measurement is CBV. Well, for DC, it's exactly the opposite. The primary measurement is really the permeability of the blood-brain barrier, which you can extract from the rate of extravasation of contrast gadolinium from the vascular space into the interstitial space. And typically that's measured with this variable called K-trans. You can also calculate CBV from DCE, but again, it's more kind of a secondary measurement. And so again, you get very similar information again, and the way you apply it is very similar to what we saw before. The last thing I wanted to show you for perfusion imaging, and then I'll take a little break to ask you if there are any comments or questions. you know, I showed you that these techniques could be used to differentiate primary glial tumor from brain metastasis, progression from pseudo-progression, that it can also be used, you know, I didn't show you example, but to differentiate brain tumor from a mimic, like a multiple sclerosis plaque. The thing I wanted to insist, though, is none of those techniques is 100% perfect. So none of those techniques is 100% specific and 100% sensitive. That's why typically when I told you it's typically elevated for this and decreased for that, because again, there are of course exception. And so that's why you always have to take that information with a grain of salt. You of course have to also take that information together with the rest of the imaging exam and with the rest of your clinical evaluation. And that's also why, you know, at times we'll perform more than one technique so that hopefully they converge towards the same solution and they increase our confidence in the diagnosis. And what I just say is true for DSC, but it's true also for DCE and for ASL. So none of those techniques is perfect. But again, they all provide some additional information, come with a few pitfalls, and when they converge towards the same response, they are usually pretty reliable. So I'm just going to take a little pause here to ask if there are any questions or comments on perfusion imaging.
No, thank you. This is great. I do have a question about the utility of these techniques in low-grade gliomas, particularly in patients that have already been treated, in which, you know, there's no significant enhancement, but there's this flare on the IDH mutant gliomas.
Yes.
What is your experience?
So a couple of things. So in those lower grade glioma studies, looking at groups of patients, have shown that as the grade of the low-grade glioma increases, the CBV, for instance, increases. But that's again for groups of patients. You know, when you look at one individual patient, given the variability, it's extremely hard to predict for one individual given patient what's the grade based on the CBV. So again, it works well for groups of patients. It does not work as well for individual patient. You know, same thing, I'll talk in a bit about spectroscopy, and same thing in groups of patients. You know, spectroscopy, especially looking at lactate and lipids, has shown that again, the amount of lactate and lipids tends to increase with the grade of the tumor. And again, that works well in research when you compare groups of patients. It's a little bit more difficult to extrapolate for individual patients. And nowadays, we also try to perform 2HD spectroscopy, but I think that still needs, you know, to be, you know, fully validated. And again, I suspect it will work very well for groups of patients. We'll have to see how it holds when you apply the technique to one individual patient in terms of how sensitive and specific it is.
Randy, Ashish, any comments?
Great talk, Max. Really nice to meet you and hear all this. You know, I think what is your guys' protocol for obtaining these? You know, we typically get perfusion on all follow-up scans, you know, really after the first one. Are you getting this preoperatively to establish a baseline? Are you doing every other scan? What's your guys' protocol?
Yes, so a couple of years ago, we changed our protocol. We do something slightly different for patients with primary brain tumor and patients with metastasis. But for both, we get ASL because ASL, again, it's a relatively short sequence. It lasts a couple of minutes. It doesn't require any contrast or anything. So therefore, we obtain it routinely at all time points, baselines, and follow-up. What we have started to do is also get routinely DSC. And the rationale here is that we're going to inject contrast anyway for the post-contrast T-weighted images. Typically, when you inject contrast to get good post-contrast T1, you don't want the tech to image the patient too quick because if you inject and immediately you acquire your post-contrast T1 weighted images, then the problem is the contrast may not have had the time to extravasate in those areas with increased blood-brain barrier permeability. So that's why we kind of use the perfusion, because it's the same bolus that's injected. We acquire images while we inject the bolus. And in some way, it forces the text to wait the appropriate amount of time to get the post-contrast T1 weighted images. The only downside is that you typically need to do the injection with a power injector. So the patient needs an IV line as opposed to being able to just inject the contrast with a butterfly. So that's the only downside for the patient. But we do it routinely for all our patients at baseline and follow-up. And then for patients, and that's all we get, so the regular T1, T2, gradient echo, diffusion, ASL, DSC, post-contrast images. For patients who have a specific question where we're not sure, or the results are contradictory, we have a protocol, a dedicated protocol called ABTI for advanced brain tumor imaging. And for that, we get the same as the above, so the ASL, the DSC, but we also get the DCE, and we also get spectroscopy. And that we do it in a targeted manner when there is a clinical dilemma and we're not sure exactly what we're looking at, so we get additional information. The downside for that is you have to inject 2 doses of gadolinium contrast, one for the DCE and one for the DSC. So that's the downside for the patient. Those days, we don't want to inject too much gadolinium. And if you do that, you want to do the DC first before you do the DSC, because otherwise the DSC will negatively impact the measurement in the DC. So you always want to do the DC first before the DSC.
Great,
Thank you.
All right.
Yeah, if you want to keep on
Okay,
with
I'll keep
spectroscopy.
going. I think I have time at least to do the spectroscopy, and then you'll have to have me back for the next part, So let me talk to you a little bit about spectroscopy. So spectroscopy, it's actually the way MRI was originally created. Originally that's what folks would do, would be to look at those different spectra of metabolites. And then after that, we learn how to create images from that signal, but the original way magnetic resonance imaging was created was actually spectroscopy. So when you do spectroscopy, or let me start. When we do MRI in general, the signal that we typically collect is the signal of water, because water is the element that's the most commonly present in our body. And so the signal that you see on all MRI images that you are looking at is actually the signal of those hydrogen atoms in the water molecules. That's really what creates the signal that we see on T1, T2, and all the other sequences that we're looking at. So when you do spectroscopy, you basically cancel the signal from the water, and that allows you to look at the signal of all the other metabolites that are hidden beyond that massive amount of water. And typically, you're still looking at hydrogens, but you are looking at hydrogens that belong to different molecules compared to the water molecules. And so the hydrogens, when they belong to the water molecules, they oscillate at a certain frequency. But when the hydrogen belongs to a different molecule than the water molecule, they oscillate at a slightly different frequency. And the difference is minimal. It's not calculated in percent. It's calculated in part per million. And you can then calculate what's the difference in frequency compared to the frequency of the hydrogen. And you can express that difference again in part per million. And based on the difference, it gives you a very specific definition of which metabolite you are looking at. For instance, if the frequency differs from the water frequency by 2 parts per million, that's typical of that metabolite called N-acetyl aspartate. If it is different by 3 parts per million, it's typical of creatinine. If it's different by 3.2 parts per million, it's typical of choline. And so that's the way you can basically create those spectrum that we interrogate in spectroscopy. So the couple of things that I wanted to mention perhaps is there are multiple ways to do spectroscopy. The concept is always the same, but there are multiple ways to do spectroscopy. A first division is whether you do short echo or long echo spectroscopy. If you do long echo spectroscopy, you're going to see fewer metabolites. You're only going to see the big one, the creatine, the choline, the NAA, and it's going to be relatively clean. You are not going to have a lot of noise. So the downside is you only see a few metabolites. The good side is that there's very good signal to noise ratio. So that's why typically we do a lot of long echo spectroscopy. Whereas if you do, like what is shown here, short echo spectroscopy, you can potentially get access to a lot more metabolites, but there's also a lot more noise. And so sometimes you see a lot of fluctuation, but you don't know if it's really the metabolites or if it's just noise in your spectroscopy acquisition. So that's the first two variants of spectroscopy. The next thing that you can do is you can take advantage that there are ways that you can manipulate the spectroscopic results. And I'm going to give you one example. When you look at lactate, depending on the MR acquisition, depending on that echo time that you pick, the lactate peak is going to either point up or point down. And it's typically going to be in that lipid region. So a very good way to confirm that something that you think is lactate is to repeat the same spectroscopy in the same location, but with different time of echo. And you should see that peak of lactate invert itself, going from positive to negative. And I'm explaining all that technical detail that's probably of little interest, just to say that then there are smart ways of doing spectroscopy where, you can get two different echoes, and then you can do a subtraction, and that way you can enhance differences like the lactate peak or like the 2HG, and you can extract that information from the spectroscopy. So that's kind of what I wanted to show you. In a nutshell, so that's what, when you do, again, the most frequent one, the long echo spectroscopy, that's what it's going to look like. So we use the creatine, again, around 3 parts per million as a reference. And typically, it's going to, set the standard for all the metabolite. Again, in a normal voxel, in a normal brain tissue voxel, the NAA, the N-acetyl aspartate, which is a marker of neurons, is going to be higher than the peak of creatinine, whereas the choline is typically going to be the same, slightly above or slightly below the creatine peak. What I'm telling you is, of course, a simplification. There are changes in that general rule I give you based on the age of the patient. As the brain of the pediatric patient is myelinating, these changes. Also, it depends a little bit in the region of the brain, the basal ganglia, the hemispheric white matter. They have slightly different spectrum, but that's a kind of a good thing to remember. And when you deal with a tumor, so again, you use your creatine peak as the reference. So typically here you can see that the NAA peak has kind of vanished, and that tells you that the neurons have been affected, have been damaged, and therefore their peak is going down, while the choline peak is increasing. And the choline is a marker of a glial membrane. So when the choline peak is increased, it tells you that you have an increased turnover of membrane, which you typically observe with processes like brain tumor. Like I told you earlier, spectroscopy is not specific either. It's not that you see that pattern and you can say, okay, it's a brain tumor, because, for instance, an active MS plaque could give you the same pattern. You could also have a decrease in NAA, and because there's increased turnover of glial membrane, you could also have increased choline. So typically the NAA is not going to be decreased as much, and the choline is not going to be increased as much, but you are going to see similar type of changes, again, less pronounced, but similar change. And finally, as I told you, you can look also at other metabolites like the lipids and the lactate, and those are the ones that in groups of patients have been associated with the grade of the tumor, with the amount of lipid and lactate increasing with the grade. Again, working well in research when you compare groups of patients, not necessarily working as well when you look at individual patients. So here again are your, the different metabolites we looked at, typically where they are in terms of their shift, their chemical shift in terms of their frequency compared to water. And again, the Na is a normal marker, the creatinine is your reference, and the choline is a marker of membrane turnover in tumor proliferation, but also other condition. And when you do spectroscopy, so there are a couple of ways. I already talked to you about the long and the short echo. I talked to you about those dedicated spectroscopy for lactate and for 2HG. What you can also decide to do is you can do single voxel spectroscopy versus multiple voxel. And of course, there are pros and cons to the two approaches. One of the cons for multivoxel spectroscopy is that it takes longer. It takes a longer time for the patient to be still in the MRI scanner. The other thing that you also have to be very careful is also that if the region you are interrogating with spectroscopy contain any water or fat, is going to completely throw the process off, because the signal from the water or the signal from the fat is going to completely overwhelm the signal from those rarer metabolites that we're interested in. And so typically when we do spectroscopy, we carefully position the region we're interrogating, either the single voxel or the multiple voxel, to try to avoid any contact, mostly with the fat located in the bone marrow. And so that means that if we have a lesion that is really superficial and close to the skull and the bone marrow, it may be hard to interrogate by spectroscopy, because invariably, when you position your voxel, you're going to capture a little bit of the fat of the bone marrow, and then the spectrum that you will observe will be just a mess. Similarly, if the lesion itself contains a lot of blood products, so if it's a lesion that contains lipid products, it's also probably going to mess up your spectroscopy. And so that's why typically, as I told you, we get the spectroscopy as part of our advanced brain tumor imaging protocol. But again, we look at those patients first, because if we see that the lesion is too superficial, if the lesion contains too many blood products, we're not going to expose the patient to being 10 more minutes in the scanner when we know that we're not going to get any meaningful results. And again, I wanted just to show you that lactate with that doublet. And again, I don't think I have the images to show you how it can flip from being positive to being negative, but again, a nice way to look at lactate. And again, lactate and lipids in groups of patients have been shown to correlate with the grade of the tumor. And again, I'm going to pause here, and I suspect that I'll be up by my time, so I'll have to come back a different day to talk about DTI. And also I wanted to, give you just a first exposure about a very new imaging techniques called magnetic particle imaging. I'm sure you have never heard about it before. It currently only exists in a preclinical manner, but we hope to bring it to the clinical realm soon, and it's very good at tracking cells. So that will be for next time.
Thank you. This was great. In terms of the spectroscopy, is there a size limit for a lesion that is too small that may not be worth doing it? Or can you comment on that?
Yes. So the voxel, so it's all a question of signal to noise ratio. So if typically in order to be able to collect enough signal to be able to detect those per million differences in frequency, you need to have a certain size of voxel. If you have a tiny lesion, you can still do the spectroscopy. Typically, you'll do then a single voxel instead of doing the multiple voxel, and you'll get another single voxel in the contralateral hemisphere where it's normal to serve as a reference. And the problem is the lesion is too tiny. You are going to collect signal from the lesion, but you're also going to collect signal from the normal surrounding tissue, and it may dilute the spectrum that you're looking at. And the spectrum may look kind of normal, but just because you have a lot of normal tissue and very little abnormal tissue. So typically you need the lesion to be at least 1 centimeter to be able to extract some meaningful information out of it.
What are your thoughts on on this new 3D MR spectroscopy, whole brain kind of MR spectroscopy and its utility, as we're moving forward?
Yes. So again, the pros and cons, the advantage is you cover a larger volume. Another advantage is tumor is heterogeneous. It's not like, you get one piece of information that average the tumor and it gives you the answer. So the 3D spectroscopy from that perspective is very helpful. The downside is the duration of the acquisition, because of course it takes a lot longer. And of course, you are trying to detect those minuscule differences in terms of the frequency of resonance. And so you need the patient to be perfectly still. And so, of course, for perfect patients who can stay completely still for the duration of the exam, the 3D spectroscopy is great. But often our patients, after 45 minutes in the scanner, they want to get out, they start moving, they breathe, they cough, they snore. And all of that then is a lot more likely to affect negatively the quality of your 3D spectroscopy. So it's this compromise between getting theoretically better information, but being exposed to the practicality of a moving and a breathing patient.
Absolutely. And then the last question I had to follow up on that was the utility of MR spectroscopy to detect immune infiltration in the settings of infections and in the setting of, different types of immunotherapies now that we're treating people. Has that been looked at before?
Yes. So again, as I shortly alluded to earlier, spectroscopic results are non-specific. It's not that you use
Right.
the Na and the choline. They occur. Lactate and lipids are also observed in infections. They have been used to try to characterize abscesses, to differentiate different types of abscesses and toxoplasmosis, to try to differentiate in between glioblastoma and lymphoma. So there is definitely an application. The challenge again is the lack of specificity. So it's helpful. It's not perfect. It doesn't always give you the final answer. That's why to have perfusion imaging spectroscopy and to see a convergence of the result helps you. But it's not that there is one perfect technique where you get one set of results and they have 100% sensitivity and specificity. And in part because again, they're influenced by various conditions, not just brain tumors.
Thank you.
Thank you for the wonderful talk. I had a question with regards to like the sensitivity for your DCE and ASL in terms of diagnosing a lesion, say progression versus pseudoprogression. How often you have to go to MR spec to sort of confirm your diagnosis there?
Yes. So again, I don't know that I have an exact number, but again, to be realistic, so first you have the patient time course, because you kind of know when they got their surgery, when they started getting chemo and radiation, and there's a certain timing of radiation therapy changes. So that of course helps you. We look also, at the pattern of enhancement, because of course, if it's very feathery, there's not a lot of mass effect, that may push us more towards radiation therapy changes. Whereas if there's more bulk-like enhancement, that's going to push us more towards tumor recurrence. So what I'm trying to say is not you just look at the perfusion, like you incorporate all the information. The perfusion, of course, adds confidence when you see that either the cerebral blood volume is very decreased or that it's very increased. It helps you. The reality is doesn't always happen, and there are some cases where you're right in the middle and you don't know if it's really decreased or if it's really increased. And in those settings, getting different types of perfusion plus the spectroscopy often helps, but so at times you'll get discrepant result, and one technique will tell you it's tumor progression and the other one will tell you it's just treatment changes. So overall it helps, but again, none of them is perfect. When they are convergent, it really increases your confidence, but they also at times they are discrepant.
Thank you.
Well, thank you. We really appreciate, just to respect everybody's time, and thank you everyone for the attendance. Next week, we'll have another webinar. We'll have Dr. Aggie from UCSF talking about the management of recurrent glioblastoma. Hopefully, all of you will be able to join. Thank you, Dr. Wintermark, and we'll be in touch soon.
Thank you
Appreciate
so
you.
much. Thanks for having me
Okay.
again. Have a great afternoon.
Yeah.
Bye-bye.
Thanks, y'all. Bye-bye.
See you around.